Hello, it's a really great honor and privilege to be here with Professor Antonio Colombo, who has joined us for the 7th edition of the Bifurcation Summit organized by the Brazilian Society for Hemodynamics and Interventional Cardiology. So Antonio, great privilege to our community. These last 2 days we have been discussing so many things about techniques, advancements. It's really incredible that we're still discussing the optimal treatments for bifurcation and left main disease, and also as we're dealing every time more with complex interventions in our daily practice, this has really become a daily situation for most of practitioners. So in your view, you have been for more than decades studying this topic and developing techniques. How do you see nowadays, let's say, the optimal approach for a bifurcation lesion? If we can summarize this.
But first of all, let me spend a few seconds to congratulate for this meeting. Congratulations to you, to the society, and a lot of congratulations to the presenters. Not only nice formal presentations, but I saw very complex cases, really difficult cases, which were solved in a brilliant fashion. So it's really the quality of the operators is very high. I think there are various messages that you can take over from this meeting. First of all, the importance of optimizing the result, especially when you implant two stents. When you implant two stents, you take responsibility of the short-term and long-term patency, and the thing that the operator can do is to have an optimal lesion preparation and an optimal result. And I strongly believe that this will go back 20 or 30 years of the value of intravascular ultrasound or OCT. When you implant two stents, in my view, is a must. When you implant one stent, it's a little bit different. The result from the side branch has to be good, but should not necessarily be stent-like. And the other message is the continued value of provisional approach. Provisional approach is not a must, but it's something that the operator should try. If he has to decide for two stents, is not a complication, but he has to understand that if he can get away with provisional, may be better.
Other thing that we have discussed and recently at PCR, there's a lot of discussion about the applicability of drug-coated balloons and in the role of bifurcation, even complex disease in overall. How do you see, it's a little bit of going back to the past, you know, with the balloon angioplasty, I have been trained only with stenting, and we see now maybe that's a new era starting, and so the new fellows, the trainees, should be also learning again how to do a optimal balloon angioplasty and to consider drug-coated balloon as a new player.
Drug-coated balloons are a new player, especially for the side branch. They may simplify the procedure. The advantage over an optimal implanted IVUS guided stenting versus drug-coated balloon may be small. But if you can make the procedure quicker and easier and have the same long-term result, why not? So I believe you still need a good angioplasty result, because drug-coated balloon doesn't make a bad angioplastic result a good angioplastic result. Even if sometimes this happens due to positive remodeling, we should not look at that. So you need a good angioplastic result. Some dissection can be tolerated. Angioplasty is working also by making non-occlusive dissections. So dissections are part of the angioplasty procedure, which in parentheses, this is an issue that young operators don't tolerate, close parentheses. So drug-coated balloon should be considered. What is missing? We have no data. We have anecdotal cases. We have some case series, but sooner or later we need a reasonable, well-conducted randomized study to give evidence to support these hypotheses generating intuition at the present.
Yeah. And one thing that you stressed in this meeting also was the dual antiplatelet therapy, especially when you're dealing with complex techniques, meaning double stenting or more stents in the coronary. If you look at the recent data, I mean, a lot of trials, maybe the Nesta is a recent trial that taking the, let's say, complex interventions and proving that could be safe to have a very short depth therapy. Other studies suggesting the same. I don't know how much well represented. It's like double stenting techniques, left main, but the overall message is that you could do it safely if you have to. What's your recommendation if we're dealing with complex techniques in terms of depth? Should we be a little bit more careful with this?
But a short DAPT, what does it mean? 15 days, 1 month, or 3 months?
Like 1 month, the very short.
1 month, I believe they mastered up. Congratulations to all the investigators and to Dr. Valcimigli for doing this study. Is not sufficiently representative of very complex bifurcations, especially bifurcation where you implant 2 stents, and we have to go to real life. Even if we recommend IVUS when you implant 2 stents, in reality, not every operator uses IVUS when you implant 2 stents. So, putting all things together, I will still give at least 3 months when you do a complex bifurcation. 1 month, maybe if you implant 1 stent, but if you implant 2 stents, I will feel more secure for the patient to continue for 3 months.
And if the patient doesn't have any high bleeding risk condition, what will be your recommendation?
That you go into a more difficult area, because most probably endothelization is okay in 3 months. But if you really believe in long-term dual APT, you can continue. But these, we go a little bit beyond preventing stent thrombosis, and we go more in preventing complications of late atherosclerosis.
And in terms of the type of antiplatelet P2Y12 inhibitor agent, for 2 stenting, any consideration, or they all could be applied?
I think overall every dual antiplatelet therapy, of course now there is this trend to use a single therapy with ticagrelor and prasugrel, which in my view is very acceptable. There are studies, big studies leaders that demonstrated the single antiplatelet therapy after 1 month of dual DAPT is okay, but don't forget that when we talk single antiplatelet therapy, we don't talk about single clopidogrel, we talk about single prasugrel and ticagrelor, which is different.
We saw here a lot of young physicians, a new generation coming. What would be your message for these young physicians that are training now, facing now, let's say, the future of interventional cardiology, to give the optimal treatment and to find themselves in the best condition to treat patients?
My message is learn to do angioplasty also. It's good to learn optimal stenting, which is the main area, but don't forget that there is also room for optimal angioplasty, especially with the emergence of drug-coated balloon, which will not take over stenting, but will give some more elegant way to approach especially long disease, total occlusions, bifurcations, etc. So drug-coated balloons are not an antagonistic device to stenting, but they make PCI more elegant and maybe they give better long-term result. I say maybe because we need studies to convert maybe into EASE or R.
Okay. And lastly, again, thanking you for being here. It's really been a great experience, a great journey, a great pleasure. I will leave you to give a message to the Brazilian interventional cardiology community, not to say the medical community, having you that we see as one of the great leaders worldwide, definitely in our field, but also an inspiration to all of us.
But the message is Ricardo and all the team of Dante Passanese and the society in Brazil continue with this job, continue with this meeting where you share opinions. We are not wasting time, we are improving the knowledge and we are testing what we believe with other people's opinion, because what you believe needs to be tested and to be proven not by you but by the community.
Thank you so much.
Okay, grazie.
Thank you, grazie.